Good morning everyone, I am Dr. Nidhi and I will be talking about management of posterior capsular tear during phacoemulsification. Almost every ophthalmologist dread having a posterior capsular tear as it is the mother of all posterior segment complications. The incidence varies and even in the hands of experienced surgeons it may vary from 0.5 to 3.6%. However, in the hands of residents it may go up to around 6 to 7%. Why we fear having a PCT? Because almost every ophthalmologist dread having a posterior capsular tear as it is the mother of all posterior segment complications. The incidence varies and even in the hands of experienced surgeons it may vary from 0.5 to 3.6%. However, in the hands of residents it may go up to around 6 to 7%. Why we fear having a PCT? Tip still, and with your other hand you have to use liberally viscoelastic substance which helps to avoid vitreous moving forward. You have to go through your side port incision and put a viscodispersive viscoelastic to tamponade and reinforce the rupture site, and this bolus of viscoelastic pushes the vitreous back, and when you are removing the phacoprobe as well you have to fill the AC so that the vitreous does not follow your phacoprobe. This is a small clip in which one is doing phaco and a PCR is noted during phacoemulsification. You can just see with this red arrow there is a PCR noted. The chopper is gently removed from the side port. However, the phacoprobe is in the anterior chamber, and with the side port again we are injecting OVD to push back the vitreous and reinforce the rupture site, and after this one can safely remove the phacoprobe. Now what you do? You have to choose your surgical strategy. Take a minute to look and decide what has happened and what to do next. Identify if there is only a PCR and if there is a vitreous loss that has happened or not. Supposing there is a PCR and there are remaining nuclear fragments, and the nuclear fragments are very soft and there is no vitreous, then one can use liberally OVDs which are dispersive in type, and you can proceed with phaco. But the key is to provide some separation between the space of vitreous and area of phacoemulsification. Keep the phacotip occluded with the lens as much as possible to avoid pulling on the vitreous, and slow down speed with low bottle height and lower vacuum. And in the end you can clear off the anterior chamber with a cutter. However, if you have a PCR with remaining hard nuclear fragments which is quite large a piece, and there is a PCR with vitreous prolapse, then you should not ever proceed with phaco. It's always better to convert in such cases. How to convert anterior or posterior has to be according to the case. If there is a large piece in anterior chamber, it's better to go for anterior conversion. If the large piece is already tilted, it is already going back, it's better to let it fall back. There is no need of fishing. You just clear the anterior chamber, use a cutter, close the main wound, and it's always better to refer to a retina person. No fishing of the piece is advisable because it unnecessarily leads to vitreous tug, and it may also lead to retinal tears eventually or dialysis. If you are having a small PCR, there is no nuclear fragment, there is no vitreous, then possibly you can try converting it into a posterior capsular excess. And again, in this situation also liberal use of OVDs is advisable. This is just a small clip which shows you can do a small PCC in case of posterior capsular tear. One can use a Utrata forceps or a vitrectomy ILM forceps. In this video, one is holding the posterior capsular tear's edge with the forceps and completing the rhexis. This is same as that we do in a pediatric cataract case. This is complete. It basically converts the jagged edges into a circular edge. Now, if you have a PCR with vitreous prolapse, what you do? For a primary care center where automated vitrectomies are not available, one may consider doing a manual vitrectomy using sponge and scissors, close the wound, and again refer to a tertiary center. Because whatever we say, however we do, the automated vitrectomy is the best in such cases. This is just a small clip showing how one is doing a manual vitrectomy. One is put the lens and using a Vanna scissors to clear off the wound from vitreous, and using a bud to look for the remaining vitreous strand in the wound. So the wound and the AC has to be cleared of the vitreous. However, for tertiary care center, there is no escape. One has to do an automated vitrectomy for vitreous removal from the AC and wound, and dry aspiration can be considered for the remaining cortical matter removal. One must always remember the basic principles of anterior vitrectomy. You have to have a closed chamber vitrectomy and a bimanual vitrectomy. Closed chamber means you cannot go through the main phaco wound for vitrectomy. You have to either close the main wound and go through the side ports, and always use a bimanual mode. That is, the irrigation has to be from a separate port. Always cut before aspirating, and there is no pulling of vitreous which is advisable. You have to clear the section and anterior chamber free from vitreous. This is a picture of cutter. You always have to have the cutter facing up. The pupillary area has to be cleared of vitreous. You don't have to go down or behind the pupil. The aim is to maintain minimal traction vitreous space, so you have to maintain a low flow and maintain the anterior chamber. Usually we keep a cut rate of 800 to 1000 cutting per minute with a suction of 100 to 150 millimeter of mercury, and the flow rate has to be kept minimal, 15 to 25. This is just a small clip which is showing a grade 3 nucleus being undertaken for phaco. This is from the beginning. One is doing rexis with 26G capsulotome. Hydro procedures are being done. One can see hydro procedures with tenting up of capsule and burping. You're just removing the extra fluid out of the nucleus and rotating the nucleus. Phaco is being done. Nicely all the pieces are being taken out. And this is epinuclear plate removal with phaco 3 mode. And during this part, one just see a CR. Now what we do? Just relax, use a viscoelastic to form an anterior chamber nicely, and use dry aspiration, because as yet no vitreous has come out. You just use dry aspiration to remove the cortical matter all throughout. Keep the AC formed with visco. Never shy away from using viscoelastic in these cases. And then once you start seeing the vitreous, use a cutter to clear the vitreous from pupillary area and in your safe zone. See, the cutter's face is always facing up, and we are just in the center. We are not going anywhere behind the pupil or low down. Once the central area is clear of vitreous, we can safely put a single piece IOL in the bag, since the PCR is round and circular. Now in the end, after the IOL has been put, one can simply sweep the iris to look for remaining vitreous strands, and gentle visco removal can be done by lowering the bottle height and reducing the vacuum. Now even you've done the vitrectomy, there may be some persistent vitreous in the anterior chamber. So in the end, you must always look for these signs, that is peaked pupil. The presence of vitreous can be assessed at the wound by a dry methylcellulose sponge or a bud. And you can also consider tattooing with a triamcinolone for vitreous in AC. This is just a clip showing again a PCR noted during IA. You again a dispersive agent, do dry aspiration to remove the cortical matter using a 12 o'clock cannula. Again use a cutter to clear the pupillary plane centrally. You can also use a cutter to aspirate the cortical matter, and then in the center when you bring it, you can just cut the cortical matter because it may be mixed with the vitreous. And after you implant the IOL, one can use a triamcinolone tattooing for the vitreous and do a vitrectomy bimanually to clear off the anterior chamber and wound off the remaining vitreous. This is one of the safest techniques to remove the vitreous in the anterior chamber. And the least common time for vitreous is while placing or just after placing the IOL. Usually in this phase, very little vitreous come out. You must stabilize the IOL in this case by putting one haptic in AC and one or another in out of wound, and then assess the situation. If you can safely put it in the bag, then it's okay. Otherwise, you can put it in the sulcus. If you want to put it in sulcus, always remember a single piece cannot be put in the sulcus because it may constantly rub to the iris. You have to consider using a multi-piece IOL or a large PMMA, or if that is also not possible, you can consider using AC IOL or other types. And again, this I just told you, for a ciliary sulcus placement, if there is large tear and a well-centered anterior access, you can use a sulcus. Otherwise, anterior chamber IOL can be considered. So in the end, just a take-home message for anterior vitrectomy: one must always close the chamber. You should do a controlled chamber anterior vitrectomy and always do a bimanual instrumentation for anterior vitrectomy. Thank you for your attention.